right, well, let's talk about the aggressive or violent patient, something we rarely ever see in practice.
Never, no.
Never. If we actually look at the definition of these, aggression is behavior intended to threaten or cause harm, and violence is where you actually carry it out. Aggression is just saying it's going to happen and threatening it, whereas violence is carrying through with the aggression and actually carrying out a violent act. So, this section here, to be honest with you, if you've taken a management of assaultive behavior or equivalent class, this is a lot of the stuff you've already learned, so you'll want to draw on that. But just quickly, what are some symptoms that your patient could be escalating towards violence? And I think most of these are obvious, but they become increasingly agitated, restless. Their speech becomes loud or pressured. You see muscle tightening, like clenching of the jaws or fist. They begin to pace, intense staring, verbal threats. I mean, these are things we probably see regularly at work. They're not unknown to us, but those are some of the things that say, we're moving towards violence. So what are some things that you could do to help reduce the risk of a violent outbreak? Well, first of all, let's talk about things you can do in the environment. You want to put these patients in the quietest environment possible to decrease stimulation. In our little pocket practice books that we sell, there's really a question I really like about this, and it says, you get a patient who's agitated, what's the best place to put them? And one choice is to put them right at the nursing station where you have, you can closely monitor them. One is to put them at a jerry chair, near the entrance. One's to put them in a room with other psych patients for interaction. And one is to put them in the room farthest from the nursing station. Of course, the right answer is farthest from the nursing station. The last thing you want is them at the nursing station, because number one, you don't want to deal with it. But number two, we also, we won't want them in that high stimulation environment. So putting them in a room as far away from stimulation as possible will help to reduce some of their anxiety and the things that are building towards violence. Now, it should be obvious, but don't leave them in that area alone. They need to be monitored and have somebody with them, but you want them in a quiet place in the environment. If there's bystanders, you'll want to try to clear the area for safety reasons as quietly as possible without making a big deal about it. You want to obtain unobstructed access to the patient so that if the patient does need assistance to remind them of good behaviors, you can get to them as quickly as possible. You want to do what you can to put them in a place where there is not a lot of furniture or other items that could be used as missiles, or if they are there, to try to clear them away or keep the patient away from them. Confiscate any real or potentially harmful objects the patient may have, like their cane. And when possible, you want to position yourself so that you are between them and the door for easy egress. Now, as Brandon said earlier, though, we don't want the patient to feel trapped, because feeling trapped also increases the risk for violence. So as you think of positioning, you want to make sure you're in a place where you could egress if you need to safely, but doing so without making the patient feel like they're trapped, because that makes them have an increased risk for violence. As far as actual de-escalation or approaching the patient, do not hurry the patient. Most violent or psychotic patients can be talked down given time, and engage them in conversation and attempt to establish a therapeutic alliance. I always say I worked for many years as a hospital administrator, and then I went back to the bedside after many years in administration. And first of all, I'm going to give free advice to everybody. The job that you never want is to be a ER director. Worst job in the world. Honestly, it'd probably be better to be a garbage man than that. Because really all you're paid to do all day is listen to people complain. Nurses complain about nurses, doctors complain about nurses, families complain about nurses, patients complain about care, everybody complains about where the photocopier is in the nursing station, and you have to listen to administration complain about the budget, and you get paid less than a staff nurse to listen to people complain all day long. It's a terrible job. But why do I tell you that?
How do you really feel, Jeff?
I know. Well, why do I tell you that story? Because I learned something really important in my years of listening to people complain as a hospital administrator. And that is, when people are upset and angry, the best thing to do is shut up and listen. People don't want you to rationalize away their anger. They don't want you to defend yourself. All they want to do is get it out. And once it's out, most people talk themselves down. And what I learned listening to people complain my entire life is to shut up and listen. And yeah, sometimes it's a personal attack against me and I have to let it roll off my back like a water off a duck's back. But you know what? Whatever. It doesn't matter to me at the end of the day if you say something bad about me. I could care less. And so when I left administration, went back to the bedside, and I just let my psych patients go on and talk and not try to defend and not try to quieten them down and not try to stop them, I found most of them just talk themselves out. And that's all we need to do is just don't hurry the patient, let them do their thing, and then move on. Now, that's not 100%. There are some patients that will never talk themselves down, and you'll get that feeling, but acknowledge their feelings. Let them know that you understand their frustration, whatever it might be. Be clear, non-threatening, and honest. Allow them to verbalize their complaints and avoid confrontation. Don't defend yourself. Don't try to make it better. Just let them say what they're going to say. Appear calm and non-threatened and in control. If it looks like the patient is going to become violent, set behavioral limits and let them know what is and is not acceptable and what the consequences of their behavior would be. Speak in simple, direct sentences, And if you're watching this on video, there's a picture of a nurse who's using what's supposed to be a very therapeutic stance. So when you have someone who's angry and potentially violent, stand at a 45-degree angle to them. By turning at an angle, not only do you make yourself smaller and less of a threat to the patient, but you've also positioned yourself for easy egress if you need to. Also, you should make sure that the palms of your hands are always visible, because palms of hands are not threatening. But when the patient can't see your palms, it may be that you're hiding something, and that increases their fear and potential for aggression. So if you follow all these things, you'll never, ever have a violent patient ever again. Well, at least on the test.
Yeah. On the test. Now, if we did everything that Jeff said and magic happened, great. But if magic didn't happen, we got to look at restraints. And so this is our next slide that we're talking about here is restraints. If we have to go to restraints, we have to go to restraints. But before we do, we have to do all least restrictive interventions first. We tried all of our verbal de-escalation thing. And I got to second what you said. I did time in management, and it's a thankless job. But a lot of it, you learned how to talk to people and how to listen to people. And the only other thing I would add was acknowledge their feelings. Mm-hmm. If you can label that feeling right there and just validate that, that just does tremendous amount to de-escalate it. Offering the choices. This is your choice. If you can give some power back to the patient, if I can do environmental modifications, if I can't get them to a place that's quiet, maybe I can get rid of the bystanders. I can get rid of all the other noise behind. That's helpful. Address the physiologic causes. Are they aggressive because of hypoxia, hypoglycemia, pain, withdrawal? Maybe they just need food and water. Maybe we've had them cold in a room for 16 hours by themselves. Family or support person, if it's safe and appropriate, maybe I can have someone else there with them. And diversion or redirection, like we talked about, food, drink, bathroom. I don't know about you, I worked in one ER, we had 21 beds, and I had 17 psych patients on a Saturday night.
Oh dear.
And those patients are going to be there for 72 hours. And so you're stuck in a room by yourself for 72 hours. What else can I do to help? What can we do before we have to restrain this patient? If I didn't need mental health before I got there, I do now.
And I'm addressing this slide, when we talk about restraints, the first thing is always to have you done all the least restrictive alternatives first. Sure. And I'm always like, what are those? So that's why I put together this slide. These, when we say all least restrictive alternatives have been tried first, these are the things that you should have tried as the things on this slide.
And document that. These are the things that we tried. This is what I offered. These are things that we could think about and we put through there. If all of that failed, and now we have indications for restraints, the patient is in imminent danger to staff or self, there is severe agitation or violence, there is a failure of all of our de-escalation techniques, and we're unable to safely perform care, then we might need to do restraints. Now, if we choose chemical restraints, great. We can use benzodiazepines, we can use antipsychotics, we can use ketamine. If I use benzodiazepines, understand there's effects, there's risks. The effects, sedation, anxiolysis, muscle relaxation, that's what we're supposed to do. You're going to look like that little puppy we can see on the slide if you guys are watching it, nice and sleepy. But it's going to cause respiratory depression and hypotension. If I use antipsychotics, it's going to control the agitation, it's going to control the psychosis. But it can cause QT prolongation, cause extrapyramidal symptoms. So did we get an EKG? Are we aware of their cardiac symptoms? Are we aware of a cardiac history? We have a risk of that. It's not simple to just go give them medications and see what happens. If we use the two medications together, it's an adjuvant medication. They're going to work better together. Yay! but I'm gonna have increased risk. Now I have increased sedation, and if we're not paying attention to that, we have increased harm risk of this patient. We can use ketamine. The company I work for now, we love ketamine. We use ketamine a lot. It can be given lots of different ways. Severe violent agitation, it's a rapid onset. It preserves their airway reflexes, but it can also cause hypertension, tachycardia, hypersalivation, in rare cases, laryngospasm. Now, if we have to do physical restraints, restraining a patient against her will or his will, when there's no duty to restrain the patient, that is false imprisonment. Be aware there are a lot of legal, ethical, and moral implications with this. If your restraints are associated with skin breakdown and pressure injuries, limb injuries and fractures, nerve injuries, strangulation, increased agitation, frustration, and disempowerment. Psychologically, this is very assaultive to the patient. I can't imagine being tied down against my will, in particular the way it happens. You're being attacked by strangers and tied down against your will. That's very, very, very rough if, not done correctly. So, safety principles involved. You must have an order. Orders are time limited. You have to assess and document everything you do. Circulation, skin integrity, respiratory status, comfort of the patient. Make sure you're offering food, water, toileting, positioning. Document your patient status frequently and the ongoing need for restraints. In your documentation, the reason for restraint and the behavior leading up to it. The alternatives attempted before, the type of restraint used, duration and monitoring of the findings, and the patient response and the re-evaluation of need. Remember, it's not the type of restraint, it's the reason for restraint. We used to harp on this a lot in my ERs of where we're at. I don't care if you put soft or hards on, it was the reason that you put it on there. If grandma's confused and I can still put them on, it was still a behavioral reason or it was still a physical reason or medical. It depends on the reason you put it on, not the type.